All right, welcome everyone. My name is Amal Mattu and welcome to University of Maryland's Department of Emergency Medicine, where we are speaking. And today we're going to speak about a topic that I really love, and I hope you love also, and that is a topic of acute heart failure. In fact, because of our time constraints, we're going to really focus on the end of the spectrum with acute heart failure. We're going to focus on cardiogenic pulmonary edema. And I think as emergency physicians, we live for this diagnosis. The reason I love this topic is because I think it really exemplifies what emergency medicine is all about. You've got patients that are really sick, and they come in, they look like they're going to die, they feel like they're going to die. And if you play your cards right through some simple, inexpensive therapies and maneuvers, you can completely turn these patients around to the point that maybe even sometimes they feel like going home, but we're not going to send them home. We're going to talk about the patients that really need to come in for further workup, but you can make a big difference in these patients' lives and a big improvement in their morbidity and their mortality if you play things right. So we'll first of all begin with a simple disclosure. I'm not paid by any drug companies or device companies. I actually work for University of Maryland, so I'm kind of just barely paid in the first place. But anyway, no disclosures, and I think that's always important whenever you hear a talk on an emergency cardiac topic. So enough said. Let's jump in with a case. And there's no secrets or zebras about this case. This is the kind of case that you and I see on a regular basis. So this is a 65-year-old man who comes into the emergency department feeling short of breath. It's probably evolved over the past day or so. He's got a couple of cardiac risk factors. He comes in looking really sick. He's diaphoretic. He's got normal mental status, so he's not buying himself a tube yet. Normal mental status, but he's diaphoretic. He's tachycardic, tachypnic, hypoxic. You put non-rebreather on him and his sats come up a little bit. Again, maybe to the point that he's not buying himself an intubation, but he's still looking really sick. He's extremely hypertensive, like the majority of these patients are. You listen to his lungs, he's got crackles up to his ears, he's got JVD. You get a quick portable chest x-ray, and in fact, the x-ray comes back with letters and arrows on it. No surprises here. This is your classic cardiogenic pulmonary edema. He's got cephalization, full-blown pulmonary edema. So what have you learned to do? What have I learned to do? 100% non-rebreather, no doubt. And then you get a quick 12-lead ECG, something that you should do early on. 12-lead ECG doesn't show any ST elevation or ST depression, just non-specific junk, maybe a strain pattern. So you're not off the hook shipping this patient off to the cath lab. He's stuck with you, and you have to do your thing. So let me just give you some options here about what you would do with this patient. Now, again, he's on the monitor. He's got bilateral 12-gauge IV, so he's got good IV access. You've got your ECG, and you've got 100% non-rebreather. And my question for you is, when you see these patients, what do you normally do for these patients in the next 5 or 10 minutes? I'm going to give you some options here, all right? So choice A, morphine. Choice B, you give some furosemide or whatever loop diuretic you like. Choice C, morphine plus furosemide. Choice D, nitroglycerin plus one of the above. Choice E, nasiritide plus one of the above. And then choice F, none of the above. Maybe, I don't know, rotating tourniquets or some other option that you like. Now, I've been doing this lecture for probably about 15 years and really looking at this literature over the past 20 years. And what I would tell you is that when I first started giving this lecture, in fact, back in ASEP was the first time I think I gave this lecture to a very large audience, several hundred people in the audience. And back in 2005, when I first started this lecture at ASEP, I would say probably about 5% of the audience 10, 11 years ago would raise their hand and say, morphine's my first choice amongst the choices you've given. Maybe about 10% of the audience would say morphine plus furosemide. Maybe about 10, 15% of the audience would actually go for C. About 50% or 60% of the remaining audience would go with nitroglycerin plus one of the above. And then maybe about 10, 12 years ago, nasiritide became very popular, and a handful of hands would start going up for nasiritide. And every now and then there would be a scattering of people that would say none of the above. They had some other regimen. Well, what I hope to convince you of in the year 2016, the modern day optimal management of this patient is actually not morphine and not furosemide and not morphine plus furosemide, But the optimal management of this patient is not nitroglycerin plus one of the above either. But the optimal 2016 management is actually none of the above. And we're going to talk about what kind of things that you can do for these patients that are simple, they're relatively inexpensive, and they are extremely effective that will get these patients and take them out of dire straits and make them look a whole lot better. All right. Now, before we get started, I need to give you a little caveat. Whenever I give this lecture, there's always people that get very upset with some of the things that I talk about, because as we go through the current modern day literature, you're going to find that I'm going to bury a lot of long-held and traditional beliefs. And people get upset about that, but just hang in there, because again, this is based on what literature we have today in 2016. Okay, so this is a little outline of what we're going to talk about. We'll spend some time talking about the definition, just a little time on physiology, but I think that is important even though we don't like physiology. Just a little time. And then we're going to spend some more time on pharmacology, preload reduction, afterload reduction, and inotropic support. We'll talk about non-invasive ventilation and also some new thoughts, some new pharmacotherapies that are coming out that people need to be aware of. And then we'll wrap things up at the end. We'll go back to the case I just presented, and we'll talk about what we really should be doing. I'm not going to spend a lot of time on inotropic support. I'll tell you why when we get there, but for the most part, there's not great literature supporting one therapy or another. Non-invasive ventilation, we're going to blow through that also. It's very important, but we're just going to quickly summarize the literature on that topic. All right, so first of all, how do you define cardiogenic pulmonary edema? Well, these are some of the definitions that you see in the textbooks. You know, leakage of fluid from the pulmonary capillaries and venules, and hydrostatic this and that. It's a lot of big words there. And for those people that know me, I'm a very, very simple person. I want to keep things really simple. So I like the second definition: inability of the left ventricle to effectively handle its pulmonary venous return. You know what? Let's make things even more simple. I love simplicity. And so the way I like to think and the way I like teaching about pulmonary edema is to think of the lungs as nothing more than a bucket that's partially filled with fluid. And now you know everything you need to know about anatomy with regards to this topic. Okay, so pathology, when a patient goes into pulmonary edema, the fluid level rises. And now we're done with pathology. You know all the pathology you need to know. Increased fluid level within the bucket. Physiology, it's just a little bit more complicated. There's three mechanisms that are primarily responsible for maintaining the fluid balance in that bucket. Think of this bucket, and there's a faucet that's hanging over top of the bucket, and the faucet is always on. It's continually trying to fill up the bucket. The name of that faucet is preload. That's all there is to preload. It's a faucet that's continually trying to fill up that bucket. Well, there's a pump that's continually trying to empty the bucket, and that pump is called the heart, or more specifically, the left ventricle. And the strength of that pump is your left ventricular contractility. That's all there is to the pump. And it's continually trying to empty that bucket through a hose. And the size of the hose through which it's trying to empty the bucket is called afterload. That's all there is to afterload. It's a hose. So when afterload increases, what it means is that the hose tightens down. It gets smaller. When afterload decreases, the hose relaxes and gets bigger. That's all there is to afterload. All right. So three mechanisms: a faucet called preload, a pump called the left ventricle, and a hose through which the pump is emptying the bucket, and that's called afterload. And those three mechanisms are constantly interplaying with each other as the patient is living out their daily life. Now, when a patient goes into pulmonary edema, as I mentioned, the fluid level rises, and almost always it occurs because one of these three mechanisms went awry. Maybe somebody turned up the faucet. You know, if you turn up the faucet, that can put people into pulmonary edema, so increase preload. Maybe the patient had an acute hypertensive crisis. The blood pressure went sky high, the hose tightened down, and as you'd imagine, if the hose tightens down, it's a lot more difficult to empty the bucket, so things back up into the bucket, you end up in pulmonary edema. That's your classic flash pulmonary edema. That's your classic hypertensive crisis. We'll talk about that. Or maybe somebody went into pulmonary edema because the pump suddenly got weaker. Maybe the patient had an acute ischemic episode, or maybe the person's having a STEMI. You get that quick early 12-lead ECG, you find out. But if the patient has an acute decompensation of LV strength, that can also put the patient into pulmonary edema. So very simple. Almost always when a patient goes into pulmonary edema, it's because one of these three mechanisms went bad. Now, just a little bit further about the pathophysiology. There's a lot of different mechanisms that are at interplay with each other when patients are heading into pulmonary edema. How does pulmonary edema happen? Well, this is a little cascade of events that can occur. An acute drop in LV systolic dysfunction leads to decreased myocardial contractility and cardiac output. That produces a rise in catecholamines. What do catecholamines do? They make the afterload increase. In other words, that hose tightens down. Blood pressure may increase as well. Then you get an increase in myocardial wall tension and myocardial oxygen demand. Well, that's not good for a heart. That's going to produce worsening diastolic dysfunction, increased pulmonary artery and capillary hydrostatic pressures. That squeezes fluid out into the pulmonary alveoli and interstitium. That produces more hypoxia, more myocardial ischemia, and then that feeds back up to further systolic dysfunction. And you can see that this cycle is a self-perpetuating cycle of events that all are intertwined. And one of the key points, one of the reasons that I'm showing you this slide is because I want to make the point that a lot of people make a big deal about patients that have chronic CHF because of systolic dysfunction or diastolic dysfunction. And that's very important in terms of therapy on a chronic outpatient basis. But in the emergency department, by the time a patient gets to us, because of this self-perpetuating cycle of events that are intertwined together, by the time a patient gets to us, it almost never matters whether their original problem is systolic dysfunction or a diastolic dysfunction, because by the time they get to us in full-blown cardiogenic pulmonary edema, both of these processes are at hand. They have both systolic and diastolic dysfunction. So the therapy, the early therapy on those crashing, god-awful, sick-looking patients can be very, very similar to each other. All right. So what are your goals with regards to treating all of these patients when they show up with cardiogenic pulmonary edema? Well, number one, if somebody is in pulmonary edema, you want to decrease preload. I mean, think about it. If you're sitting in a bathtub that's overflowing with water, what's the first thing you do? You turn the faucet off. So goal number one, decrease preload. So we'll talk about how to do that. Goal number two, decrease afterload. If you make that hose bigger, you relax the hose, make it bigger, then it's much more easy to pump blood out of the bucket, right? So decrease afterload. That's going to unload the heart. And then in some patients, you may need to provide an inotropic support to improve the strength of that left ventricle, of the pump. Now, normally we don't need to do that. Normally we don't do that. And that's why we're not going to spend a lot of time talking about inotropic support, because there's some adverse effects associated with providing inotropes that we'll get to. But for the most part, if you just focus on goal one and goal two, I'd say in 90% of the patients we see in the emergency department, just focus on goal one and goal two, you will turn these patients around very, very rapidly. All right? Now, if there's only 2 slides in this entire presentation that you remember, right? That's pretty bad. But if there's only 2 that you're going to remember, please let this be one of them. All right? And I'll tell you the other one in just a moment. We talked about the lungs as being a bucket, but it's important to remember that the lung bucket sits within a much larger bucket called the body. The body is a larger bucket in which the lungs sit. And it's entirely possible for a patient to be in full-blown pulmonary edema and yet have total body euvolemia or hypovolemia, right? So this is the second slide I'm going to ask you to remember. How often does that happen? How often is a person in pulmonary edema and yet they're not fluid overloaded? Well, recent data when I say recent now, we're talking about the past 15 or 20 years, but it just hasn't filtered down to most of us as clinicians. Recent data has shown that up to 50% of patients that show up in full-blown pulmonary edema are not fluid overloaded. They simply have fluid in the wrong bucket. And so if you focus your efforts not on fluid removal, but on fluid redistribution, you will get these patients out of pulmonary edema very quickly. In other words, focus your efforts on getting fluid out of the lung bucket into the body bucket, and that's going to improve pulmonary edema, hypoxia, tachycardia, tachypnea, and the symptoms of extremis as well. So focus on fluid redistribution rather than fluid removal, especially in those extreme hypertensive patients, the flash pulmonary edema patients that are not coming in saying, yeah, I've been missing my Lasix for the past month or the past week or so, or the patient who went out and had a Memorial Day picnic with gobs of salty food. Those patients are fluid overloaded, but 50% of the time they're not. And those patients need fluid redistribution rather than just fluid removal. By the way, when you give whopping doses of diuretics, which we've all been taught to do, which bucket do the diuretics drain? Let me go back. The diuretics drain the big bucket, not the lung bucket. And that's why they take so long to work. All right, so major causes of pulmonary edema: too much preload, too much afterload, and problems with contractility. That might be the ischemic patient, the STEMI patient again. So we're getting that 12-lead ECG early. If it's a STEMI, you're sending them up to the cath lab and let them treat them that way. Now, I didn't mention disorders of rate and rhythm. Of course, patients that have unstable tachydysrhythmias or unstable bradydysrhythmias can also go into pulmonary edema. We're not going to really talk about that because that's just basic ACLS. If somebody's in pulmonary edema because of extreme rapid AFib or VTAC, you're going to shock them. If somebody's in pulmonary edema because of an unstable bradycardia, then you're going to pace them. Again, basic ACLS, so we're not going to spend much time talking about that. All right? So let's move forward a bit. And we're going to spend time talking about the goals of treatment. Remember, goal number one, decrease preload, turn off the faucet. What are the things that you can do to turn off the faucet and decrease preload? Well, we've all learned about these: morphine, furosemide or loop diuretics, and nitrates. We'll talk about each of these one at a time. First of all, a lot of people out there are still using morphine. If you're not using morphine, good for you. Here's the reasons why you've been taught not to use morphine. If you are using morphine, or maybe you're in charge of a pre-hospital system, there's a lot of pre-hospital systems out there that are still using morphine. Stop. Why is it that we are taught to use morphine? Well, there's older literature that said that morphine decreases preload. It's interesting, the main way that morphine was thought to decrease or is thought to decrease preload is because of its histamine side effect. When you give patients morphine, there's a little bit of venodilation, but if you pre-medicate the patient with an antihistamine and then give morphine, there's no venodilation. So isn't it interesting that we are all taught that morphine produces preload reduction because of its side effect? That doesn't make a lot of sense why you would want to use a medication side effect to help a patient, right? Well, the side effect also produces adverse effects as well. We're also taught to use morphine because it has some anxiolytic properties. Definitely, it does produce anxiolysis. If you produce anxiolysis, you decrease catecholamine output, and that's going to decrease afterload, which might help with vasodilation, and that's going to be helpful for that hose that we talked about. But let's talk about the reality here. What are the disadvantages of morphine? Well, we've all seen morphine produce rash, urticaria, nausea, and vomiting. What do you think is happening to the catecholamine output when patients have side effects from morphine? If they break out in a rash or urticaria, they're scratching all over, they start retching or vomiting, that's going to drive the catecholamines upwards. That's going to actually increase the afterload and make that hose even tighter. All right, so there's some drawbacks there. High doses of morphine can produce respiratory depression, which is the last thing you want to do to somebody who's already got a compromised airway and pulmonary function. And also, it's been found that morphine is a direct myocardial depressant. There's older SWAN studies where they put SWAN catheters in patients and they gave them a slug of morphine, and after the morphine, their cardiac output dropped. It's a direct myocardial depressant. That's the last thing you want to do to somebody who's got decompensated heart failure, right? And finally, it turns out that when people have actually looked at some of the SWAN studies out there, what they have found is that morphine actually does not decrease central preload. Just peripheral vasodilation, but centrally is what we're interested in. And the reason that we were taught to assume that morphine decreases preload is because of studies like this. Way back in the 60s and 70s, they did venous capacitance studies. Essentially what they did was they put IV catheters in people's wrists and forearms, and they gave them some morphine, and they found that in the wrist and forearm, there's a little bit of venodilation. So people extrapolated that and said, well, you know, if there's peripheral venodilation, it must be producing a decrease in pulmonary wedge pressure. Well, that doesn't make sense. When somebody's in extremis and diaphoretic and tachycardic and hypoxic and looking bad, I don't really care what's happening in the wrist and forearm. I want to know what's happening centrally in the lungs. What's going on with the wedge pressure? So if you want to know what's going on with the wedge pressure, you need to look at the SWAN studies. And here's a couple of SWAN studies. There's not a lot, but I'm going to show you what's out there. So in 1975, Lapis and colleagues gave 5 milligram per minute infusions of morphine to patients with decompensated heart failure, 2 milligrams per kilogram IV morphine, pretty good. And what they found was that actually left and right heart filling pressures, preload, increased and cardiac index dropped. Moving forward to 1980, Timis, 0.2 milligrams per kilogram of IV morphine to MI patients that had severe left ventricular failure. And what they found was that for the first 45 minutes, their hemodynamics worsened. Their blood pressure, heart rate, and cardiac index all dropped. Again, that's the worst thing that you want to do to somebody that's already got decompensated heart failure, drop their cardiac index. It doesn't make any sense. There was no decrease in preload. So the central effects turned out to not actually work. More clinical studies. Jerry Hoffman, a famous emergency physician out in California back in the 1980s, looked at a bunch of pre-hospital patients and found that if patients got morphine or even morphine plus nitroglycerin or morphine plus furosemide, any combination involving morphine, they had both subjective and objective deterioration. But if the patients didn't get any morphine, they just got nitroglycerin, which we'll get to, they had a significant improvement in both subjective and objective deterioration. Al Sicchetti, a well-known emergency physician from South Jersey, has done a lot of research on pulmonary edema. He looked at odds ratios for intubation and ICU admission and found that when patients got morphine with various combinations of other medications, if somebody got morphine in the emergency department, all other things being equal, morphine was associated with a 5-to-1 increase in odds ratio for needing to be intubated or go to the ICU. So you need to practice your intubations. By all means, give morphine, but that's not the right thing to do for our patients. All right? And then the biggest study so far from the ADHERE registry, Frank Peacock and colleagues looked, once again, they tried to balance things out to look for how severe the patients were presenting. So it wasn't just that patients getting morphine were sicker, but they balanced things out pretty well. And what they found was that patients with decompensated heart failure who went to emergency departments and got morphine had a higher rate of needing mechanical ventilation, ICU admission, and for the first time, the study actually showed that morphine was an independent predictor of mortality with an odds ratio of almost 5. So we now have data suggesting morphine not only makes patients worse, not only increases intubation rates, but also is associated with an increase in mortality. All right? So what about anxiolysis? Yes, morphine does decrease anxiety, but my argument would be if you really, really want to provide anxiolysis, why not use an anxiolytic? Why use a narcotic analgesic for anxiolysis when you have pretty good anxiolytics available already? What about a small dose of a benzodiazepine? Now, I'm not telling you to use benzos. In fact, the last time I used a benzodiazepine in a pulmonary edema patient for anxiolysis was more than 10 years ago probably. So it's not common that you need to. But if you really feel the necessity to use an anxiolytic for a patient with pulmonary edema, why not use a small dose of a benzodiazepine, a small dose of diazepam or lorazepam? Nobody ever sees urticaria or nausea or vomiting after a small dose of a benzo. So the side effect profile is much better, and it provides more direct anxiolysis. So again, caveat, I'm not telling you that you should routinely use anxiolytics at all. In fact, if you do some of the things that we're about to talk about and you reverse the hypoxia quickly, reversing hypoxia decreases anxiety faster than anything. But if you really feel like your patient needs an anxiolytic, why use a narcotic analgesic? Why not just use benzodiazepine? So my summary here for morphine is that for preload reduction, it doesn't work. And in fact, it's associated with a lot of side effects that may actually increase afterload. And for anxiety, for anxiolysis, if you really need it, just go with the benzodiazepine. So my conclusion, in the year 2016, I would argue that morphine has no role in the modern day management of pulmonary edema, whether we're talking pre-hospital or in the emergency department. Get rid of the morphine. Okay, so let's talk a little bit more about fluid management. For years, the cornerstone of managing patients with pulmonary edema has been make them pee, make them diurese, give them a diuretic. And the most common diuretic people use is furosemide. All right, you can take whatever loop diuretic of choice you want, but furosemide seems to be the most common. Where is the debate, right? Furosemide is the cornerstone, it's the hallmark drug for pulmonary edema patients. In fact, for decades, furosemide has been about as all-American, right, as baseball, motherhood, and apple pie. But, you know, it's interesting. As I've gotten more experienced in emergency medicine and in life, I've come to realize that a lot of things that we thought were good and pure turn out not to be quite so good and pure after all, right? And so is the case, perhaps, with furosemide. It's not bad, but it may not be as good as you think. So let's talk about furosemide in pulmonary edema patients. So we were all taught that furosemide works through two main mechanisms. Number one, it produces diuresis, definitely. And number two, we were taught that it gives you direct vasoactivity. In other words, you push that furosemide and you get an immediate venodilation, a vasoactive effect. We'll talk about that. So what about the diuresis? Yes, furosemide does produce diuresis, but we've all seen the scenario where you give the furosemide and it doesn't work right away. It takes a couple of hours sometimes, at least an hour, before you get much of a diuretic effect at all. You know, if I gave a dose of furosemide to an asymptomatic patient, they'd be peeing within 10 minutes. If you took a dose of furosemide, you won't even make it through the rest of this video. You'd be heading off to the bathroom, right? But when you give furosemide to somebody in pulmonary edema, what happens? Nothing. And so what do? You wait an hour, and then you double it. And then maybe you give some more. And then eventually, hours later, they're peeing out the Pacific Ocean of fluid. And typically, you remember your days working in residency back in the CCU, a day or two later, invariably all of these patients end up hypotensive and hypovolemic because a lot of them peed too much. In fact, 50% of the time they never needed a diuretic at all, right? Why is that? Well, the reason is that when patients show up with cardiogenic pulmonary edema, their afterload is so high that they're not perfusing their kidneys. In fact, renal blood flow studies have shown that patients in cardiogenic pulmonary edema are only perfusing their kidneys with about 20% of normal renal blood flow. So you give these whopping doses of diuretic, where does it go? It doesn't go to the kidney. It sits in the central circulation, the heart, lungs, and brain. It's not until you decrease afterload and perfuse the kidneys that the diuretic works. So we'll talk about afterload reduction in a bit. And that's why there's typically a delayed effect. What about the vasoactive effect? I was taught, many of you were taught, that, you know what, even if a patient is anuric, it's a renal failure patient, you still give the diuretic anyway because it produces immediate venodilation, right? Well, where did those studies come from? It turns out that that traditional teaching is based on the same type of stuff as the morphine studies, wrist-informed venous capacitance studies, where they put IV catheters in wrist informs and they gave somebody a slug of furosemide, and they found that there is venodilation in the wrist and forearm. But, you know, again, who cares about the wrist and forearm? I want to know what's happening in the central circulation. So let's go to the SWAN studies. If you want to know what's happening in central circulation, take a look at some of the SWAN studies that have done. I've never found SWAN studies that have shown a significant improvement after furosemide. In fact, this is what I found. Small studies, but nevertheless, here are the studies. 1973, post-MI-CHF patients, only 15 patients, but invariably what they found was that when patients got furosemide, there was actually a slight increase in filling pressures. There was no drop in preload until after they peed. after they diuresed. And so it was the diuretic effect that made a difference, not an immediate preload vasoactive effect. 1980, IV furosemide given to acute congestive heart failure patients. For the first 90 minutes, their cardiac output got worse. Imagine that. That's the last thing you want to do to your pulmonary edema patient. Drop their cardiac output by 15 to 20%. Now, to be honest here, and to be fair, we're not saying at all that when you give your diuretic to somebody, they're going to crash and burn. But the key point here is don't fool yourself into thinking that there's an immediate benefit. And here's the studies showing that not only is there not an immediate benefit, there might actually be a slight worsening for the first 30, 60, 90 minutes or so. Again, it wasn't until after they diuresed that there was any drop in preload or improvement in cardiac output. So it was only the diuretic effect. There was no immediate venoactive or vasodilating effect. 1983, IV furosemide, 1 milligram per kilogram given to MI patients that had LV failure. Once again, for the first 90 minutes, cardiac output and stroke volume got a bit worse. And then after they started diuresing, 60 to 90 minutes later, then there were hemodynamic improvements. But early on, no benefit. 1985, Francis looked at the use of IV furosemide in patients with class 3 and class 4 heart failure. And in this study, for the first 20 minutes, their afterload got worse, their heart rate got worse, their stroke volume got worse, and then after they diuresed, then they started getting better. But early adverse effects. Here's a 1990 study, and this was an interesting study. Krauss and colleagues decided to give various combinations of drugs, including furosemide, nitroglycerin, and captopril. Captopril, ACE inhibitor, is an afterload reducer, and what they found was that patients that got furosemide or furosemide plus nitroglycerin, for the first 15 minutes, their pulmonary capillary wedge pressure got worse, and then after they diuresed, then they started getting better. But very interestingly, if patients were pre-medicated with nitrates plus captopril and then they got the diuretic, those patients had an immediate beneficial hemodynamic response to the furosemide. Why would that be? Well, very simple. Nitrates are preload reducers. Turn the faucet off. Captopril is an afterload reducer. Make the hose bigger, perfuse the kidneys, and now when you give the diuretic, it can go right to the kidney because you're perfusing the kidney. So the diuretic is not going to help until after you get improved kidney perfusion. And that's what this study showed. Again, it's a relatively small study, but it was predictable and it showed what seemed to make sense. It's always nice when things in medicine kind of make sense, and this makes sense. The simple bucket model makes sense here. So pre-medication with preload and afterload reduction, those patients got better right away. So what's my summary based on the current data on furosemide for patients presenting in cardiogenic pulmonary edema in the emergency department? Furosemide produces a drop in preload, but only through its diuretic effect, not immediate venodilation. And the caveat to that is that the diuretic effect only kicks in 60 or 90 minutes later after the patient's finally perfusing the kidney. But if you afterload reduce them first, then you get that benefit right away. There's some initial adverse effects. Now, what the studies actually show, why does this happen? When you give furosemide to patients, it actually activates the renin-angiotensin-aldosterone system, which is an endogenous pressor type of system. So you actually end up increasing afterload. And so this is a little basic science of pathophys. For those that are not interested, just tune this part out. But that's what furosemide does. It activates the renin-angiotensin-aldosterone system, which is not good for hemodynamics early on. It increases afterload, and as a result, you have some initial adverse effects. And it takes a little while before it starts actually producing the diuresis in a pulmonary edema patient. In non-pulmonary edema patients, yeah, it works right away. But in pulmonary edema patients who are not perfusing their kidneys, it takes a while. All right, so my conclusion for furosemide, it should be considered probably, in my opinion, a third-line medication for modern treatment of cardiogenic pulmonary edema. All right, so let's talk a little bit more about how we're supposed to be managing fluids. What is the first-line therapy? Clearly, nitroglycerin, right? Nitroglycerin by far is the drug of choice for patients with cardiogenic pulmonary edema. I'm not going to go through all the literature. Most of you know this literature and are doing this already, but here's just a handful of articles. Interestingly, this top article by Cotter is a fantastic article. This is a European study, and they were a lot more aggressive about most of the rest of us. What they do is they give IV boluses of nitroglycerin, so not even a nitroglycerin drip, but they're giving bolus nitroglycerin, and it equates to about nitroglycerin drips of 400 to 500 micrograms per minute. Now, most of us would think that's crazy, but that's what they did. They gave boluses that worked out to about 400 to 500 mics per minute of nitroglycerin. And what they discovered was that patients had an immediate drop in preload, afterload, very rapid improvements in dyspnea, decreased intubation rates, and even though this high-dose nitroglycerin, nobody's head exploded, right? Maybe they had a little headache, give them Tylenol, but the patients did better clinically. So again, many of you may not be comfortable with those type of dosages, fine. But the key thing here is nitroglycerin is great, and you just need to be aggressive about it. All right, it's rapid, it's reliable. At high doses, 100, 150 mics or higher, you not only get preload, but you also get afterload reduction. So here's a fantastic single drug that accomplishes goal 1 and goal 2, preload reduction and afterload reduction. But you've got to be aggressive about using this nitroglycerin. Right? Now, I emphasize the point about being aggressive, and a lot of people are just not aggressive about nitroglycerin. If you want to use nitroglycerin drips, you should be shooting for 100 to 150 mics per minute, not the wimpy 20 mics or 30 mics per minute. Let me put things in perspective for you. I'm sure everybody watching is very comfortable with giving sublingual nitroglycerin to chest pain patients. We've all written the order many times. Sublingual nitroglycerin, Q 5 minutes. When you give sublingual nitroglycerin every 5 minutes, you are essentially giving somebody the equivalent of a nitroglycerin drip at 60 micrograms per minute. If you give nitro Q 3 minutes, you're essentially giving them about 80 mics per minute of a drip. So when you're giving somebody a drip of 20 or 30 mics, you know what? I said that's wimpy. Just turn it off and go back to sublinguals. That's a lot better. Be aggressive about your nitroglycerin drips for pulmonary edema. Right? And you might need to remind your nurses that you're not giving nitro for chest pain, you're giving it for preload and afterload reduction. So what I typically do is I start right at 50 or 60 mics per minute when I start a drip. That's the equivalent of giving your sublinguals. If you're not willing to be that aggressive, forget the drip. Just use your sublinguals. That's more aggressive than your 20 or 30 mics per minute drip. And titrate that up very, very rapidly. I'll shoot for at least 100 mics per minute. Some of my colleagues are even more aggressive. A lot of people are a bit uncomfortable. But the thing is, you've got to titrate upwards very rapidly if you want to improve these patients' condition very rapidly. Be aggressive. The other nice thing about nitroglycerin is it has a short half-life. So if for some reason your patient does drop their blood pressure, you can always just hit the off button on your drip, and it goes away within a minute or two. So it's very nice. So in those occasional circumstances where the patient has what you thought was pulmonary edema, it turns out to be a big pneumonia, and they're actually dehydrated, the nitroglycerin goes away very quickly if they drop their blood pressure, so it's perfect. Now, you always, of course, need to be careful about using nitroglycerin when patients have valve problems. If they're hypotensive already, then we're not using it. Acute mitral regurg, aortic stenosis, pulmonary hypertension, these patients are preload dependent. And, of course, always ask your patient if they're on sildenafil or any of those erectile dysfunction medications. Those of you from New York will recognize Viagra Falls up here, all right? So you've always got to ask. And for those of you that have been out in practice for a while, you know, as I've experienced in my patient care as well, when you ask patients, are you on any medications, if they're on Viagra or one of these medications, they'll say no. They don't consider it a medication. So you have to specifically ask, are you on Viagra or sildenafil or any of these other erectile dysfunction medications, because otherwise you may end up giving nitro, and those patients can have a precipitous drop in blood pressure if they are taking any of these medications, so make sure to ask. All right, so summary for nitroglycerin. It's better, faster, and safer, more effective, more literature than morphine and furosemide. If you run into problems, you hit the off button and it's gone within a minute or two. You can't say the same thing for morphine or furosemide, can you? If you run into problems with either of those medications, you can't take them away. Nitroglycerin is gone within a couple of minutes. And once you start them out aggressively, you start them out with sublinguals and then move to a nitroglycerin drip. Topical. People talk about topical nitroglycerin. You know what? I always have considered sublingual nitroglycerin to be the best thing to start with, and just skip the paste. Nitropaste, you know what? Nitropaste is very erratically absorbed in sick patients. So just forget the nitropaste. Go to a drip if you're going to stick with nitroglycerin. All right? So nitroglycerin, summary and conclusion, this is your first line medication, but be aggressive with using your nitroglycerin. Okay. What else can we say about fluid management in these patients? Well, let's go to goal number 2. We've talked about turning the faucet off, decrease preload. What about decreasing afterload? You make that hose bigger, and suddenly even a weak heart can empty the bucket much more efficiently, right? It'll improve cardiac output when you decrease afterload. It'll restore renal blood flow. It perfuses the kidneys. So nitroglycerin at high dose gives you preload and afterload reduction. Nitroprusside is a direct vasodilator. We don't really like using nitroprusside often unless somebody has crazy hypertension, and nitroglycerin alone is not doing the trick. Nitroprusside can give you kind of wide fluctuations in blood pressure. You need an arterial line. It's a little bit of a high maintenance drug. What about hydralazine? Hydralazine is a great afterload reducer, but it's not so great in pulmonary edema patients that are sick because it's not titratable, and it can give you unpredictable drops in blood pressure. So we don't really recommend hydralazine. What about ACE inhibitors? Well, ACE inhibitors are one of the cornerstone treatments for chronic pulmonary edema, but I think it's important that you need to know that they can be very successful for acute cardiogenic pulmonary edema as well. Let me share some articles with you. Again, these are all relatively small studies. By the way, nobody's studying this anymore because ACE inhibitors are cheap. They're inexpensive, so you're not going to see big studies on this anymore, unfortunately. There's no drug companies out there that are funding studies like this, so all we have are the small studies and a lot of national experience and international experience with this, but they tend to work pretty darn well. Here's a study from 1991, 25 milligrams sublingual captopril. Your normal captopril, you just dip it in water, stick it under someone's tongue, it dissolves a little bit easier. I always dip it in water, by the way, just because people that are real tachypnic tend to have very dry mouth. So dip it in water, stick it under the tongue. If somebody's blood pressure was under 110, they just cut the dose in half. So they were using it in patients with borderline blood pressure also. And take a look at what it did. It dropped the afterload, but it also decreased preload. So goal 2, but also goal number 1, and no significant change in heart rate or mean arterial pressure. And these hemodynamic benefits were observed within 10 minutes. Interestingly, in this study, they comment about 12 additional patients that presented with fluid pulmonary edema in extremis, and they had almost complete resolution of their shortness of breath within 15 minutes. That's how quickly this stuff can work. 8 out of 12 patients had an abrupt increase in diuresis without ever getting a diuretic. Imagine that. You give an ACE inhibitor to a patient, and suddenly they just start peeing. Why would that be? Well, remember, if you decrease afterload, you now start perfusing the kidney. The kidneys are pretty smart. I think they have their own little brain, right? The kidneys are pretty smart. And if you're fluid overloaded, they will make you diurese. You simply have to perfuse them first. And that's what these ACE inhibitors did. They helped perfuse the kidney, and so patients will have an abrupt increase in diuresis. That's been our experience also. And in my practice, what I'll typically do is if I use an ACE inhibitor, I give the ACE inhibitor, and I don't give any diuretics until about 20 or 30 minutes after the ACE inhibitor. And then they get the diuretic. But interestingly, we'll go up to the patient ready to give that slug of furosemide and look down in the Foley catheter bag, and 20, 30 minutes after the ACE inhibitor, there's already 400 or 500 cc's of urine in there because they're now perfusing the kidney. They start diuresing. You try it, you'll see the same thing happen. The ACE inhibitor helps them diurese. Okay, more studies. Langs, this was a German study where they had IV captopril, and again, onset of action within 6 minutes, decreased preload, decreased afterload, improvements in cardiac output, no adverse effects. Varial, 1993, they gave 1.25 milligrams of IV enalapril, which is what we typically use, and they use this in patients with severe heart failure and severe mitral regurgitation. And take a look, increased cardiac output, increased stroke volume, slight decrease in mean arterial pressure and in systemic vascular resistance. So in other words, it dropped the blood pressure in those patients that were extremely hypertensive In other words, it drops the afterload, which means it makes the hose bigger, decreases in preload also, and decreased magnitude of the mitral regurgitation. Al Sacchetti, that study I referred to earlier, looked at odds ratios for intubation and ICU admission. Sublingual captopril significantly dropped the need for intubation or ICU admission. Right? So I'm not going to go through all the literature that's out there on ACE inhibitors, but there are studies that talk about the use of sublingual captopril, IV enalapril, and even it works in dialysis patients. I remember back when I was in residency, I worked with Al Sacchetti back when he did this study. We worked at a hospital across the street from a dialysis center, and so every evening we would get these patients that missed their dialysis. Imagine that, non-compliant dialysis patients. So we would get these patients that had missed their dialysis, 4 or 5 patients every evening who would come in with full-blown pulmonary edema, and in many of these patients, we wouldn't even put IV catheters in. We would simply give them sublingual nitro, sublingual captopril, and within 15-20 minutes, they were looking and feeling a whole lot better, and it would buy them several hours before they would need their, before they'd go over for their dialysis. So it really does work. When I came over to University of Maryland, I was working at Mercy Hospital, and in our Pyxis, we had captopril, so I started using sublingual captopril when I moved over to university at Mercy Medical Center. Then when I moved over to the main university hospital, we didn't have sublingual captopril, we only had IV enalapril, so I switched over and now I use IV enalapril. Same difference. I'm not aware of any studies saying one's better than the other. Sublingual captopril, IV enalapril, it's a wash. Whichever one, you get very, very quick hemodynamic and subjective improvements within 6 to 12 minutes. That's the benefit of aggressive afterload reduction. All right, and here's a study that hasn't been published. It was presented at Academic Emergency Medicine. Southall and colleagues looked at the use of sublingual captopril in New York Heart Association Class 4 patients. In giving sublingual captopril, they found no increase in hypotension, no increased need for vasopressors, significant drops in ICU length of stay from 3 days down to 1 day. So my summary here for ACE inhibitors, you get rapid afterload reduction, which is what they're intended to do, but they also give you preload reduction. It decreases the need for intubation, ICU admission, ED, and hospital length of stay. And the combination with nitroglycerin is better than either one alone. So you can use both the nitroglycerin and the captopril. And if somebody can't get nitroglycerin for whatever reason, an allergy, maybe they're on some medication for erectile dysfunction, whatever, it's a great single agent because it gives you some preload reduction also. So my conclusion is that you've got nitroglycerin number one. I like ACE inhibitors as my second line agent for these patients. Now, let me take a step back from ACE inhibitors for just a moment. I don't want to stand here and say that you absolutely have to be using ACE inhibitors. The reason I like talking about ACE inhibitors is just to emphasize the importance of afterload reduction. And these medications, in my experience, work very, very well. But if you don't want to use ACE inhibitors, that's fine. Key point, be aggressive about afterload reduction. If you simply want to go with aggressive use of nitroglycerin and you're willing to titrate that nitroglycerin up rapidly, perfect. Skip the ACE inhibitors. Key point here again is not that you've got to use ACE inhibitors, but you've got to use preload reduction and afterload reduction. You've got to use both. And whether you use ACE inhibitors or simply high-dose nitro, it doesn't matter. You've got to do both if you want to get these patients out of extremis quickly. And just to really hammer this home, this is my favorite study from all of the pulmonary edema literature. This was a Japanese study. Tai and colleagues looked at the effects of thermal vasodilation in 34 congestive heart failure patients with a mean ejection fraction of about 25%. So these are chronically fairly sick patients. Now, what is thermal vasodilation? Are they infusing hot water or lava, or what exactly is this? Well, it's very interesting. What they did was they told patients, sir, if you let us put a Swan catheter in you, we will let you sit in a sauna for 15 minutes. That's it. That's all they did. They simply took these patients and they sat them in a sauna with the Swan, I guess, for 15 minutes. That's it. Now, think about what a sauna does, a hot sauna. Because of all the heat, you get significant venodilation, and with enough venodilation, you get some vasodilation, so preload reduction afterload reduction. That's all, no medications. And what did the SWAN show after 15 minutes of sitting in the sauna? Significant decreases in preload, goal 1, significant drops in afterload, goal 2, significant decreases in mitral regurg, and significant increases in cardiac index, stroke volume, and ejection fraction, goal 3. It did everything just sitting in a sauna for 15 minutes. No medications. It's amazing. So for anyone out there who's building a new emergency department, make sure you put a sauna in there. Absolutely part of your modern day management of cardiogenic pulmonary edema. Okay, so we've got to talk about natriuretic peptides for a moment, and just for a moment, because there's been a lot of talk in literature about, over the years, about nasiratide. So what are natriuretic peptides? These are hormone-like substances produced by the myocardium, and they modulate fluid balance, sodium balance, that's the natriuresis, it refers to sodium balance, vasodilation, venodilation, and so on. So these are endogenous substances. Well, a number of years ago, and normally they're produced by the left ventricle, and the left ventricle will increase production when it gets distended and stressed. So researchers a number of years ago said, well, you know what? When a person has chronic CHF and they have an acute decompensation, they often can't produce enough extra, so let's create an artificial or a recombinant form of this natriuretic peptide, B-type, which refers to brain-type natriuretic peptide, which is produced in the ventricle despite its name. Early studies found that when you infuse this natriuretic peptide, this recombinant form called nasiratide, when you gave it in through an IV line to these patients with acutely decompensated CHF, there was drops in preload, drops in afterload, increase in cardiac index. So everything sounded perfect. When I saw these early studies, I said, this is the drug we've been waiting for. No increased heart rate, no arrhythmias, symptomatic improvements. However, the subsequent studies that came out were not quite as glowing. Number one, it was primarily a preload reducer. It didn't do as much as hoped for afterload. And it turned out that when the original studies were performed, they really didn't compare nasiratide versus aggressive use of nitroglycerin like what we're talking about, or other things that we're about to talk about also, like non-invasive ventilation. So these patients were not optimally treated. So if you give a medication to patients that are not being optimally treated, yeah, it might show some improvement. It was also a lot more expensive than nitroglycerin. There was some improvement in their signs and symptoms, but you know, what can we say about nasiratide? It hasn't properly been compared against optimally treated patients. And in this lecture, we're talking about optimal treatment. We're not talking about just give a little morphine and furosemide. We're talking about optimal treatment. Those studies haven't been done. So again, what we can say about nasiratide is that it decreases preload, but it's not really proven yet. There were some early studies, by the way, that showed perhaps some renal dysfunction, and that's been debated, maybe no renal dysfunction. There were some early studies that suggested increased mortality. That's been debated also, and probably it doesn't worsen renal function or mortality. But the key thing here is we already have some really good, cheap therapies that work. So do you really need to add nasiratide on top of that? Well, I'm not sure. I don't think the data has proven that yet. I would say perhaps the one group of patients in whom nasiratide might be useful is patients that are in need of a prolonged infusion, because if you put somebody on nitroglycerin drip for a long time, they start developing tachyphylaxis to the nitroglycerin drip. That doesn't really happen with nasiratide. So if you have an OBS unit, for example, and you're treating patients with decompensated heart failure for 18, 24 hours on a drip, nasiratide might be useful in those patients. But for the routine management of the majority of our pulmonary edema patients in the ED, I would say right now in the year 2016, nasiratide is not indicated. Okay, we're almost there, folks. What else can we do? We've talked about preload reduction, goal 1. We've talked about afterload reduction, goal 2. What other help can we provide to the patients? Goal 3, in some patients, you might need to provide inotropic support. If somebody is too hypotensive already to get preload reduction and afterload reduction, you need to give them an inotrope. Maybe if your patient is having a STEMI and they are in pulmonary edema, and it's going to be a little while before you can get them reperfused, you may need to add an inotrope there. What are your choices? Well, dobutamine is the traditional inotrope of choice. If they're very hypotensive, people have talked about adding dopamine or norepinephrine. For years, I used to talk about using milrinone, and these were essentially bridges before you get them to the cath lab for an intra-aortic balloon pump. Right? So what can we do to support them before they get to the cath lab or the OR for that balloon pump? Dopamine, dobutamine, norepinephrine. I really liked milrinone for a number of years. And I'll talk about why I liked milrinone. The catecholamine class of drugs, the dopamine, the dobutamine, the norepinephrine, those all work pretty well on blood pressure, but there's some drawbacks, right? They produce tachydysrhythmias, which means they can increase ischemia. They can increase afterload, which is not good. They increase myocardial oxygen consumption. Dobutamine might actually drop your pressure a little bit because it does give you a little vasodilation at the same time. Also, chronic CHF patients have already large amounts of circulating catecholamines in their system, so their adrenoreceptors are already upregulated. So chronic CHF patients oftentimes develop tachyphylaxis very quickly in response to catecholamine drugs. The other drawback is that most CHF patients nowadays are on beta blockers. And if somebody's chronically on a beta blocker, they're not going to respond to these catecholamine drugs because their adrenoreceptors are being blocked by the beta blockers. The whole purpose of beta blockers is to counteract the effects of catecholamines. So now when you give them a catecholamine, it's not going to work well because of the chronic beta blockers in their system. So that's why researchers and I started thinking, well, maybe milrinone is the answer. Milrinone is a phosphodiesterase inhibitor. It works outside the adrenergic system, and so it should work even well in patients that are on beta blockers. It also produces some preload reduction, afterload reduction, some inotropic support. There's no concerns about tolerance, but the reason I don't really spend any time talking about this any longer in particular is because the most recent studies have shown no mortality benefit compared to dobutamine and dopamine. So my conclusion is very simple. If you need to give an inotrope to a patient with cardiogenic pulmonary edema because they're hypotensive, use whatever you want. The fact is, there's no good literature that says milrinone or dopamine or dobutamine or norepinephrine are better than anything else. Use what you're comfortable with, but keep milrinone in your back pocket because if your catecholamine drugs, your norepi, dopamine, dobutamine, they're not working because the patient's chronically on beta blockers, milrinone might be your answer. But again, no mortality benefit, so I can't strongly say that one thing is better than the other. What else? Non-invasive ventilation. I said we were going to mention it, but not spend a lot of time on it. Let me just say right up front, if there's one therapy that works really well, probably the most important therapy you can give to somebody who's got cardiogenic pulmonary edema, it is non-invasive ventilation, CPAP and BiPAP. It maintains patency of fluid-filled alveoli, keeps the alveoli open so the alveoli won't collapse. That means you improve air exchange. It also increases intrathoracic pressure, and by increasing intrathoracic pressure, you get a decrease in preload, you get a decrease in afterload, goal 1, goal 2. You decrease afterload, you perfuse the kidneys better, you improve cardiac output, goal 3. So non-invasive ventilation, CPAP or BiPAP all by itself can improve goal 1, goal 2, and goal 3. But you've got to use it early and aggressively. The literature is profoundly positive in favor of non-invasive ventilation. So I'm not going to take you through all those articles, but just to summarize what non-invasive ventilation has been shown to do, it decreases the work of breathing, it makes patients feel better faster, improves air exchange, decrease ED and ICU length of stay, decreases intubation rates, decreases hospital costs, and there's some suggestion that it may be associated with a decrease in mortality as well. It's a little controversial, but this is probably the only thing I've talked about in this entire session which has come even close to showing data of improvements in mortality. So unquestionably, if there's one therapy you've got, go with non-invasive ventilation. The drugs are all secondary. But make sure to use it early. Don't wait till the patient's crashing. As soon as the patient hits the door, get it on board. Use it early, early, early. All right. Now, finishing things up, what kind of research do we have out there, new research? Unfortunately, there's not a lot of great new research on pulmonary edema that has been changing our practice in the emergency department. But there are a few new concepts that have emerged based on some of the recent articles. These are a couple of articles. The one at the top by Colin Starrow and Kirk in Annals of Emergency Medicine is a fantastic read. If you want to get one review article, that's the one that I would recommend. Just an absolutely outstanding article. And what a lot of the current modern thinking about how to manage these patients is focusing on now is taking a look at the patient's blood pressure on arrival. So the arrival blood pressure. And this is one of the diagrams out of that Annals article where they talk about splitting your patients up into either hypotensive, normotensive, or hypertensive heart failure. How much hypertension is that patient suffering from when they arrive? With the hypotensive pathway, hypertension obviously being defined as just blood pressure under 90 or so, what they want you to consider is the fluid bolus. And then just to summarize this, you're probably going to need to use one of the inotropic agents or vasopressors that we talked about. Enough said about this. The hypertensive pathway, this is defined as a systolic blood pressure greater than 140 at arrival. There's a strong emphasis on using vasodilators now because people are finally realizing that the big problem these patients have is not on too much fluid, but fluid in the wrong bucket. So vasodilators will help redistribute the fluid. How do you do that? You can go aggressive with nitro. In this article, they talk about sublingual or IV ACE inhibitors, meaning sublingual captopril or IV enalapril. Or in this article, they also mentioned hydralazine, which personally I would not recommend. I would just take hydralazine out of the equation because, again, it's unpredictable in terms of the amount of vasodilation that you get, and it hasn't really been well studied in acute pulmonary edema patients. And then after that, you gently start the diuretic because a lot of these patients don't need much in terms of diuresis. And you'll notice that as you go down this algorithm, there's more emphasis later also on adding more vasodilators. So hypertensive heart failure group of patients, it's all about early and aggressive vasodilation and not going crazy with the furosemide early on. Enough of the summary. And then with normotensive heart failure, these are patients that, again, they talk about using vasodilators in these patients and also a bit more emphasis on the diuretic. But the early emphasis is always, in all of these, is on trying to preload and afterload reduce these patients if their blood pressure can tolerate. If they can't, you're going to go off to the nitrates. So what are your vasodilator choices? Nitroprusside, I mentioned already, it's high maintenance. I'm not a big fan of nitroprusside. I'm not a big fan of hydralazine because of unpredictable drops in blood pressure. High-dose nitroglycerin, perfect. That's your first-line therapy. Sublingual or IV ACE inhibitors, outstanding. You don't even need the ACE inhibitors if you're aggressive about the nitroglycerin drip. Nasiritide, decent preload reduction, not so great afterload reduction. We already talked about nasiritide. There are some new things on the horizon that I just want to mention. I'm only going to mention them because they're not yet approved for use. Serelaxin, ularitide, and also, I'm not even sure I can pronounce this, omecamtiv mecarbil, which is what I refer to as a pseudo-inotrope. So just a word or two about these new vasodilators. Serelaxin, first of all, is a recombinant form of a hormone that mediates vasodilation, and that means you get improvements in cardiac output, and vasodilation produces an increase in renal blood flow. It produces an increase in inotropy, but without increasing myocardial oxygen demand. So that sounds fantastic. And some of the early trials have looked pretty darn good, although bear in mind that the early trials tend to use long infusions more than what we think about in the emergency department. It's not yet approved by the FDA. I'm hoping that trials are done using aggressive use of this vasodilator in the emergency department setting for acute use, not 48-hour infusions. I don't want patients in my ED for 48 hours, but acute use. And again, keep your eyes open for further studies on serelaxin. It's not yet available from the FDA. Ularitide is another one that's on the horizon, not yet available. But this is kind of a next generation nasiritide drug. It's a recombinant form of natriuretic peptide producing vasodilation, diuresis, and improvements in sodium balance as well. Once again, early trials have shown improvements in afterload as well as in shortness of breath and preserved renal function. We'll see how the data shakes out there. My hope is that one of these two drugs is going to work. And then finally, omecamtiv mecarbil, I refer to as a pseudo-inotrope because, well, it improves inotropy without actually producing the side effects that most inotropes do. Essentially, it's a cardiac-specific myosin activator, so it improves contraction, it improves the power, the stroke power within the heart, but it doesn't increase myocardial oxygen demand, it doesn't increase blood pressure or afterload, it doesn't increase tachydysrhythmias either. It produces an increase in left ventricular systolic ejection time, stroke volume, and it may actually decrease the heart rate, which is good in a lot of these patients because that's going to decrease myocardial oxygen demand. Again, this is still at the stage of early trials, so we're going to have to see how those things turn out. All right. So we've covered a lot of stuff, and let's just go back and summarize what we've talked about. So, first-line agent, nitroglycerin, is great for preload reduction, and if you're willing to be aggressive about it, it's fantastic as an afterload reducer also. So that means it's a great single agent. If you don't want to go aggressive on nitro, you can add the ACE inhibitor. I like the ACE inhibitors, IV or PO, or it can be used even instead of nitroglycerin if the patient can't tolerate nitroglycerin. Third line, after you've gotten some vasodilation or renal perfusion, after you've done your afterload reduction, then you can add in your diuretic, and you'll find it works very quickly. Even at small doses, it'll start working very quickly. What about morphine? Well, I always remember that campaign from Michael Jackson and Nancy Reagan back in the 1980s. Just say no to narcotics. Just say no. There's no good indication, and they can actually be harmful. So get rid of it. And nasiratide, there might be some more studies coming out, but right now it's not a routine drug in the ED. It hasn't been studied against optimal management. Maybe it's useful for your OBS patients, observation unit patients. Inotropic support, use whatever you're comfortable with because there's no good data that says one is superior to any others. Non-invasive positive pressure ventilation, CPAP or BiPAP, take your pick. Go with it early, go aggressive with it. Don't wait until patients are crashing. Get them on this as soon as they arrive. There's a lot of data supporting this. And then on the horizon, we'll see what the data shakes out for serelaxin and ularitide, which are both upcoming vasodilators, and that pseudo-inotrope I referred to, omecamtiv mecarbil. We'll see. We've got our fingers crossed that one of these is going to turn out to be a useful emergency department drug. So, finishing up, let's go back to the case that we started with. A 65-year-old man who came in with shortness of breath worsening over the past handful of hours. He's got cardiac risk factors, as the majority of patients do. He's got significant hypertension. What would I say is optimal management in the year 2016? Well, the first thing we're doing is that as soon as he arrives in that ED, he's looking bad, we're getting him on CPAP or BiPAP, non-invasive ventilation. The next thing we're doing is we're giving sublingual nitros. We're slipping it under the mask, Q5 minutes or Q3 minutes times 3 or 4 doses, maybe the nitroglycerin spray that the paramedics have. We're very aggressive about that. And then the next thing we're doing is either we're getting them on a nitro drip and we're titrating very rapidly to a minimum of 100 to 150 mics per minute, sometimes up to 200, or what's even easier is we'll just give them a quick shot of 1.25 milligrams IV enalapril, or you can use the sublingual captopril. There's decent data and a lot of experience saying that these work very, very well. So now we've got non-invasive ventilation, preload reduction, afterload reduction, and then, again, our practice, 20, 30 minutes later, then they get the furosemide. And by the time you give them that furosemide, they've already probably diuresed quite a bit. So in my experience, a lot of these patients end up needing only 20 or 40 milligrams of furosemide because they're already diuresing. And remember, 50% of these patients weren't fluid overloaded in the first place. So when you give them these whopping doses of diuretics, a lot of them never needed any in the first place. So remember that optimal 2016 modern-day management treatment of cardiogenic pulmonary edema should focus on fluid removal, not just focused on fluid redistribution. Right? So with that, I want to thank you for your time and attention. I really hope that what we've talked about has been helpful to you and improves the care of your patients in the emergency department. Take care.